I'm Krista Lamb, and I'm so excited to be here today to host this panel for the Novo Nordisk Network for Healthy Populations at the University of Toronto. We'll be discussing some of the network's projects and learning about how these innovative programs are poised to make an impact on reducing type 2 diabetes risk. Welcome to each of my guests. To start, I'll ask you to introduce yourselves and tell the audience who you are and what you do. First, Dr. Lorraine Lipscombe.
Hi, Krista, and hi, everyone. Thank you so much for having me today. I'm Lorraine Lipscombe. I have the privilege of being the executive director of the Network for Healthy Populations, and I'm also a researcher in diabetes health services.
Wonderful. And Dr. Calvin Key.
Hi, everyone. My name is Calvin Key, and I'm an assistant professor at University of Toronto, an endocrinologist, and a scientist working with the network researching type 2 diabetes in ethnically diverse populations.
Amazing. And Dr. Baiju Shah.
Hi, I'm Baiju Shah, and within the network, I'm the research chair for the equitable care of diabetes and related conditions, and I'm also a health services researcher and professor at the University of Toronto.
Wonderful. And so, Baiju, let's start with your project. You are working on some workplace screening, and so I'll let you tell us a little bit about what the project is and how it's going to help with the prevention of type 2 diabetes.
Yeah, great. Thank you. And it's a really exciting project. We're working with Purolator Incorporated, which is one of the large delivery companies in Canada. And it really is a project that they have driven from the beginning. And it's part of their interest. During the pandemic, they got very interested in the mental health of their employees. And then as we've started to come out of that, they've now started to move into focusing on the physical health of their employees. And they were interested particularly in cardiovascular and diabetes risk. This is a population, many of them, who are drivers that are quite sedentary in their occupation, and therefore are at risk for diabetes. And also because they are on the road a lot, don't necessarily have the great access to healthcare because they're not necessarily at home when the doctor's offices are open. So the idea of this project was to bring diabetes and cardiovascular disease testing to the workplace. So Purolator set up this program where at 3 sites across the country, they did some testing of people who are their employees, testing them for diabetes, high blood pressure, high cholesterol, did some health screening questionnaires, looked for mental health challenges. And then for those who were interested, they had the option to continue over the following year in a health coaching intervention. So virtual visits on a regular basis with a health coach who could provide support for the employee for whatever health condition they might have had or that might have been identified at the time of the screening at the beginning. And then everybody was invited back at the end of the year to have their testing all redone. And now we're working with them to look at what changed and what improved in the population who received that intervention.
So a lot of people don't think about doing interventions for health in the workplace. Why is that important?
I think there's a number of reasons why it's important. I mean, first of all, many of us who are of working age spend a lot of time in the workplace. And so it's sort of a captive population that's ready and available for these kinds of interventions. And when you have an employer who's interested in promoting health, I think it's a great opportunity to really take advantage of that and allow these kinds of projects to flourish, to support the employees and make sure that they can get those kinds of health interventions that they may not be able to get otherwise. Particularly in this time when a lot of people don't have family physicians, they don't have access to primary care, and in this specific circumstance where even the job may take them away from their access to primary care, it's important for other ways of delivering health interventions to come into play. And that was really what I think drove the interest from Purolator itself, was that they just wanted to see if they could provide this service for their employees as a way to keep their people healthy.
And I know from working with a number of people with type 2 diabetes and even type 1 diabetes that sometimes people are really afraid to disclose that they're living with these conditions while they're at work. And they really feel like there's a bit of stigma towards them. How do programs like this potentially help with overcoming that stigma?
Yeah, I mean, I think there's two important things that it does. Like, first of all, it sends the message that the employer cares about the health of the employees and is working to improve it. And so therefore that hopefully reduces that sort of concern that the employer might penalize you for having a health condition or not look favorably upon you. So it just sort of reinforces that the employer is taking sort of a more positive and proactive view to health. The other piece for this particular project, and I think is also probably important for most workplace interventions, is that it was done at arm's length from the employer. So the screening program, the longitudinal follow-up, all of that was done separately by healthcare providers who were contracted by the employer, but who were not, not part of the employer. And so the employees were therefore reassured that it was still healthcare within a healthcare context, so that their information would be protected and that there would not be sort of disclosure of anything they talked about back to the employer.
Excellent. Yeah, I see why that would be of interest, that they wouldn't necessarily want their employer to know that they are living with this condition. But all right, then. And so what we'll do is we'll move over to Calvin, Dr. Calvin Key. Why don't you tell us a little bit about your project? What is it, and how will it help people potentially prevent type 2 diabetes?
Sure. And so I have to give credit for this project. The idea for this comes from somebody named Dr. David Campbell, who is a scientist and endocrinologist at the University of Calgary. And he came up with this idea on cardiovascular self-management, education, and support. And this idea really comes from the fact that prevention of cardiovascular events such as heart attack and stroke takes a lot of work. And in people with type 2 diabetes, attending diabetes education in a one-on-one setting with a diabetes educator can be very valuable, but also takes people a lot of time to attend these sessions, costs a lot in terms of resources, healthcare provider time, and is often not the most optimal way for some people to learn about preventing these heart attacks and strokes that can happen among people with type 2 diabetes and with other risk factors such as high cholesterol and high blood pressure and chronic kidney disease. And so the intervention that he came up with is actually using a very innovative strategy that traditional programs have not considered in the past, and that's using marketing principles. So we all know that advertisers really have really effective ways of catching our attention, watching commercials on TV or even getting ads in the mail. And so we really haven't tapped into all this knowledge into capturing the psychology of people with with type 2 diabetes and people with other conditions, to get them really engaged and excited about preventing heart attack and stroke. And so his team teamed up with an advertising firm with expertise in this area to actually design a mail-based campaign that uses these advertising principles to catch people's attention. And these mail-based postcards or mailers are written in the perspective of a fictional person named Moxie, giving people tips on how to take their medications, how to eat a healthy diet, how to do physical activity, and why it's important to do these things and how it plays a role in terms of prevention of cardiovascular disease. And they tested this out among thousands of people in Alberta and found that there was actually an astounding 36% reduction in the frequency of people going to the hospital after participating in this program, which was delivered just by mail, along with some other other aspects of this intervention, which included people getting gifts in the mail and really feeling that they were part of this program and being engaged one-on-one with this person. That was a fictional personality, and people really resonated with this. And so this was really amazing, and it was published several years ago. And the inspiration for our project really comes from this original project, which was called Access in the original study. And so in the original study, the population of Alberta that was enrolled and that was the primary audience for this intervention was mostly white and English speaking. But we know that in Peel region and other parts of Toronto and Ontario, that our community is very multicultural and ethnically diverse and linguistically diverse as well. And so our idea was to really take that intervention and culturally adapt it and also translate it for communities in Peel region that are really at disproportionately high risk of getting cardiovascular disease. And so we're currently focusing on 3 populations to start, Punjabi populations, Tamil populations, and Caribbean populations. And we're really focused on culturally adapting the content of these mailers. So we've selected over 30 of them to test out. And we're working with a group of really dedicated patient partners to look at every sentence that's written and to rewrite some of the content where needed to be more culturally appropriate. And eventually we're going to go on to the next step of translating the content so that everyone has the opportunity to benefit from it. And we hope that when we test it out, that we'll see very similar results of this initiative.
And I know you mentioned Dr. David Campbell, and one of the things he's known for, and one of the reasons I'm such a huge fan of his work, is that he uses a lot of really interesting communication strategies to make the research accessible or to find out if there are ways to reach people where they're at. And so I'm just wondering how the communication strategies will play into this, in your opinion, and how do you think it will lead to this being successful?
Yeah, so like traditional self-management education is delivered typically in a one-on-one setting or in a group-based format, and it's quite didactic and goes through facts that people should know, and it works for some people, but not for everyone. And so this project, which we're now calling Moxie, uses a very innovative strategy of mailing out these messages from this fictional person named Moxie. And these messages are really written in sort of a really engaging and sometimes quirky voice. Uses a lot of humor, a lot of examples, historic examples, anecdotes. I can think of one example about reducing salt intake, which is really important to preventing heart disease. And the way that this was written originally was going back to Roman times and how salt has been a really important part of cooking for thousands of years, and how it's played such an important role in human civilization. And that seemed to get a lot of people's attention, and people can relate to it. And then it then delves in deeper about, well, salt intake is really important, but it's also not good if we take too much of it, and going into it that way. And people really seem to gravitate towards that kind of communication, that kind of messaging. And with what we're doing, we're adding sort of another dimension onto that. And so this was reviewed among the cultural groups that we're working with, and they really thought that this message of salt is very important, but it could be delivered in a more culturally appropriate way, considering the history of colonialism, some of these groups. And so the Punjabi participants in particular talked about how salt was a really important part of salt production was really important in India during the rule of Gandhi, and how it played an important role in the protest of British rule, and how that has meaning among people in this community, many of whom are older generations and who may have lived through this time. And so I just really thought that example is very striking in terms of how we use this content and use this really novel engagement strategy and communicate in a way that resonated with these ethno-linguistic populations.
Yeah, it's going to be really interesting to see the results and the things that you come up with to share with people. So we'll be looking forward to seeing those resources. Now I'm going to turn to you, Dr. Lipscombe, and ask you a little bit about your project, because your project in many ways is sort of starting very early in the lifespan. And so why don't you tell us a little bit about that?
Thanks, Krista. So my project, which is called ADAPT-M, which stands for Avoiding Diabetes After Pregnancy Together with Moms, is a diabetes prevention program that we developed specifically for women who had gestational diabetes during their pregnancy. We are starting early on because obviously gestational diabetes is treated during pregnancy. It affects about, maybe, as most people know, maybe 10% of pregnancies, and it's treated during pregnancy actually to make sure that the baby is healthy, right? But what we're learning, and what we've learned over the last couple of decades, is that even though it's temporary and it goes away in most after delivery, it does serve as a marker for higher risk of going on to develop type 2 diabetes in the women, in the mums. And so we tell women that, but unfortunately, they're not offered any plan to help prevent the diabetes. And so I started down this path probably over 10 years ago now, when I was actually practicing and taking care of patients with gestational diabetes. And I would tell them that, you have a higher risk of getting type 2 diabetes, but it can be prevented with, healthy eating and physical activity and maintaining a healthy weight after you deliver. But, we didn't have anything more to offer them. We said, go talk to your family doctor about this. Evidence was showing that this was really not enough to help women actually prevent their risk of progressing to diabetes. We also heard from many women through interviews and surveys and many studies that women do feel abandoned after delivery. They feel like they get mixed messages because, the diabetes gone away. You can go and focus on your new baby and you can put your health aside for now. But wait, you're at higher risk of getting diabetes, and with the highest risk in the next 5 to 10 years. And so and then they get busy. Nobody's paying attention to their risk and to the follow-up for diabetes. They get busy with their baby, and sure enough, many of them will go on eventually to get diabetes. And so we created this program about 10 years ago now, based on principles of diabetes, of health behavior and support specifically for women. And so it was based off of a program at Women's College Hospital where I practice, called the Women's Cardiovascular Health Initiative. And this is a home-based or mostly remote coaching program for women who are at high risk of cardiovascular disease. And they're given 6 months of coaching and education support for diet and physical activity to optimize their heart health. And we were finding that many of our patients with diabetes, older patients with diabetes, were going through this program, and it was really effective. And so we went to them and said, we'd love to see this model maybe applied to a different population, young women who've had gestational diabetes, younger mothers. And so we worked with them to actually modify their program and create one specifically geared to postpartum women, geared to diabetes prevention, and could be delivered by people who have core skills and mandate to deliver diabetes prevention, i.e. diabetes educators. And so we were able to bring together diabetes educators willing to be trained to actually help us develop and then deliver the program. So we went through a trial. We're finalizing the results of that trial, but now lots of studies in the meantime have come forward to sort of support providing diabetes prevention programs, structured programs like that, that are tailored to new mothers and accommodate their realities of being, postpartum. there's a lot increasing evidence that these programs work and that they are acceptable. And when we ran it through over 300 women, we got very positive feedback. They really loved the program. They felt it really met their needs for support, for education. They were able to access it. Over 70% stuck with it for over 6 months. And so now we have the privilege for our current phase of this program to actually implement it and test it in 3 regions of Ontario, and one of them being Mississauga, where the network is based.
And one of the things that you highlight there is that postpartum life is very chaotic. So you're coming home, you've got a brand new baby. The last thing you're thinking about realistically is your potential diabetes risk.
Yeah.
So why is it so important to incorporate the realities of life after a baby into a project?
Well, there are a couple of reasons for that. First, we know that this, even though this is a busy time for women, and many of them, would probably prefer to focus on this later, we know risk rises early. Evidence suggests that the first 5 years is really the highest risk period for getting diabetes in women with GDM. We also know that programs that are offered actually in the first year postpartum are actually more effective than if you intervene later. And that's probably for a couple of reasons. Number one, they have just come off a pregnancy where they were getting a lot of support from professionals around, healthy diet, physical activity. And so building on that, that education that they already received actually is shown to be much better than, while it's still fresh in their mind after delivery. So our program builds on what they already learned, helps them to continue to sort of use some of the strategies that they learned in pregnancy. The third issue is that this is a time where there's a lot of changes, understandably, going on in a woman's life with a new baby. She may have other children at home. She may be changing her work situation. All of those things, can happen in that period. She's also recovering from a pregnancy. And so that is a time where, we feel is important to intervene because that's a time where you can integrate healthy habits into a demanding time rather than letting women kind of figure things out for them their own. It's a time where habits start forming, lifestyles change, and so we can come in there and make sure that they're set up for healthier life and healthier habits. But of course, we know that it is hard to engage this population. So our program has adopted a number of strategies to help make sure that they can access the program, that they can stay motivated. It's customized to their needs. A lot of it's delivered over the phone remotely. We accommodate resources for mom-baby exercise, for example, eating while breastfeeding, things like that. So we feel like that at least provides a little bit more relevance and accommodation for this population.
Wonderful. And so thank you each for sharing a little bit about your projects. And I want to ask a few additional questions, and we'll kind of do it in a little bit more of a round robin style. So I'll start with you, Dr. Shah. Why is it really important that we find new ways to engage people in health interventions? Because each of you has sort of presented something that's a little bit different than what people might expect from a health intervention. So I'd love your thoughts on that.
I mean, I think it's because we know that the sort of traditional sort of standard health approaches don't always work and they don't reach everybody. And there are people who need these interventions, and in particular, maybe those that are at highest risk, for whom traditional approaches don't work and are either not relevant to them or don't speak to them or aren't in their language or are not available. And so looking for alternatives and other ways of delivering these healthcare interventions, I think is important to allow people to get access and to get care that they need.
Wonderful. And I'll follow up, Dr. Key, with a question that is somewhat similar, but I think really reflective of the work that you talked about, which is why is it so important that we have culturally tailored solutions that we're looking at instead of looking at one size fits all?
Yeah, no, it's extremely important when we're talking about these sorts of behaviors, including diet, physical activity, which are so important for managing type 2 diabetes and preventing heart disease. So I'll give you one example, which is smoking cessation, which is really important for people to prevent heart disease. And it was a really big part of the original access trial and the MOXIE intervention. When we're talking about smoking, there's different ways that tobacco is used in different cultures. There's chewed tobacco, and in other cultures, smoking is really taboo, and it's not a really big part of the culture at all. And so it makes sense to really tailor your message towards the community, and which is why I think that it's so important to culturally adapt these interventions and to make it really specific to each community. And so what we've done here is try to take one program and to make it into 3 unique programs for 3 unique cultural groups. We're not trying to make it into one program for all cultural groups. And I think that approach has a lot of merit. And I think that we're going to see the benefits of that when we test this out among people in the community.
Excellent. And Dr. Lipscombe, why is it important to the network that you support sort of novel projects or projects that are doing things that are a little bit outside of the expected?
Thank you for that question. Well, we're all about innovation at the network. Many people, around the world have, done great work to develop and implement and evaluate programs for diabetes prevention. But where the challenges lie are things that you've heard is one, reach. So for Dr. Shah's project, his project is meeting people where they're at. So taking the principles we know from other types of programs, but then adapting them to a workplace environment. We also know, cultural relevance and cultural context matters so much. And so Dr. Key's project is really great at that example of being able to reach people from different cultures and even different languages, which is, again, really, really great. And then the third, my program is really, again, around access, reach, and customizing a program to a unique population. So for the network, these 3 programs speak to contextual factors and innovative ways of implementing evidence-based strategies, right? So the second thing is that these 3 programs really address needs that we have heard from our local population, or unmet needs around access to health services, around culturally tailored programs, and around education and awareness, and diabetes screening is another big thing, which I know Dr. Shah's program also involves. So we're really responding to the local needs for better diabetes and health services for this population.
Wonderful. And so those are my questions for all of you today. And what I wanted to do before we wrap up is I'll ask my final question that I ask everyone, which is there anything that we haven't touched on today that you think is important for this conversation? And your answer can be no, but I always like to make sure that we've gotten in everything you think is important before we wrap up.
I mean, I think I would say one of the things that's really important for any of this kind of work where you're doing innovative approaches is to make sure that you've got the buy-in and the engagement of the people that you're working with. Right. So as I mentioned in my project, like it really came from Purolator, and they were doing it anyway and wanted to have some proof that it was beneficial so they could make a business case to continue it or spread it or scale it. So I think ensuring that the people on the ground and the leadership and that sort of all along that that chain, that people are supportive and engaged and involved, really makes a big difference in making sure things can be impactful and actually change what happens.
I will just say that we're just really fortunate to have those partnerships in place that Dr. Shah alluded to. That we, to be able to co-design our work with the people who are going to stand to benefit the most.
And just to piggyback on that, to really recognize the involvement of the community organizations and patients who have driven the co-adaptation of these of this intervention, we've been working very closely with Roots Community Services, Temple Society of Peel, and One Heart, which are the three organizations that are very active in these cultural communities, and without whom we couldn't have done this work.
Wonderful. Well, thank you to all three of you for joining me for this conversation today. It's been really, really interesting. And I will let everybody who is watching or listening know that you can find more information about the Network for Healthy Populations on their website. We'll make sure that we have the URL in the show notes. So thank you all.
Thank you.